Bismillahirrahmanirrahim. Today I am discussing ECG interpretation. ECG interpretation. Electrocardiogram paper. The electrocardiogram paper is a graph paper where for every 5 small square 1 millimeter you can find a heavier line forming a large 5 millimeter square. Here you can see the vertical lines and the horizontal line. Both the lines are heavier line and smaller lines or lighter line. After every 5 line you can find a heavier line, and between the two heavier lines there are 5 small squares which is equal to 1 millimeter, and the large square which contain 5 small square is equal to 5 millimeter. The vertical axis measures amplitude of the heart's electrical current. The vertical line or the vertical graph measures the amplitude of the heart electrical current. It is measured in millivolts. The current is measured in millivolts. By standard, 10 millimeter is 10 millimeter in height equal 1 millivolt. These 10 squares are equal to 1 millivolt. These are 5 square, so they are equal to 0.5 millivolt. The horizontal axis measure time. This axis measure time. On a standard ECG, the paper speed is 25 millimeter per second. Therefore, each millimeter square on the horizontal axis equal 0.04 second. This one small square is equal to 0.0 second, and each large square is equal to 0.20 second. From here to here, between the two heavier line, the 5 squares are equal to 0.20 seconds. Electrocardiogram calibration. At the beginning of the electrocardiogram recording, the electrocardiogram automatically performs a calibration. An electrical 1 millivolt signal is sent per 0.2 second, recording a rectangular shape with a 10 millimeter height and 5 millimeter wide on the graph paper. This image let us know the calibration used during the recorded EKG. This is an N-shaped sign which is present at the beginning or in the end of the ECG, and it contains vertically 10 small square and horizontally 5 small square. So the amplitude of current is 1 millivolt, and 1 square is equal to 0.5 millivolt, and 1 small square is equal to 0.1 millivolt, and 1 small square is equal to 0.04 second, and 1 big square is equal to 0.20 seconds. This is the standard calibration. You can see that it contains 2 big square. 1 big square is equal to, vertically it is equal to 1 millivolt, 0.1 millivolt, and big square will appear on ECG paper during recording. The complex PQRST, and sometimes it contains U wave, make up a depolarization and repolarization cycle. The P, Q, R, S and T complex, this represents the complete cardiac cycle in which depolarization and repolarization of the heart occur. P wave represents arterial depolarization. Here the SN node, from here the current is originated and it spread on the atria and depolarize it, and this depolarization cause appearance of P wave on the ECG paper. During recording, the P wave appear on the ECG graph. Spread of electrical impulse across the atria from the SI node lead to atrial depolarization. In healthy individual, there should be a P wave preceding HQRS complex. P wave is followed by QRS complex. This is ECG paper which contain the graph, the heavier line and the lighter line, and the small square between the heavier line and the ECG recording. And this is the one PQRS complex which record the complete cardiac cycle in which depolarization and repolarization of the heart occur. PR interval on ECG paper during recording. PR interval. The PR interval begin at the start of the P wave and end at the beginning of the Q wave. Here is the start of the P wave and beginning of the Q wave. So from the start of the P wave and beginning of the Q wave, this interval is called the PR interval. It represents the time of electrical activity to move between the atria and the ventricle. QRS complex. The QRS complex represents the depolarization of the ventricle. It appears as three closely related waves on the ECG. The Q, R, and S wave represent spread of electrical impulses through the ventricular depolarization. This is the Q, R, S complex, and this, when the ventricle is depolarized, this complex appear on the ECG graph. Q complex has two arms and the S complex also has two arms, and the R complex also has two arms. The deflection of R complex is upward and the Q and X complex is downward below the baseline. This complex shows the depolarization of the ventricle. Wave appear on ECG paper during recording. T wave. The T wave represent ventricular repolarization. This is the T wave and it shows the ventricle is repolarizing. This T wave appear on the ECG graph. It appear as a small wave after, so it appear after the QRS complex. RR interval. The RR interval begin at the peak of one R wave and end at the peak of next R wave. It represents the time between two QRS complex. This electrical impulse spread over atrium through AV node and bundle of His. Between this RR interval, the electrical current spread through the bundle of His and spread over the atrium through AV node and bundle of His. ST segment. Isoelectrical point. No change in the electrical activity. ST segment. There is no change in the electrical activity. Q interval. The QT interval. The QT interval began at the start of the QRS complex and finish at the end of the T wave. Q and T interval. This start at the beginning of QRS complex. Here the QRS complex is started, and this is the end of the T wave, so it is end here at the T wave. It represents the time taken for ventricle to depolarize and then repolarize. Confirm detail before the ECG interpretation. Check the following detail. Confirm the name, age of the patient. Match the detail of the ECG. Check the date and time that the ECG was performed. And check the calibration of the ECG, usually 25 millimeter per second and 10 millimeter 1 volt. This is the caliber which present at the beginning of the ECG. Sequence to read and EKG or ECG. Stepwise approach, purpose of the steps, and clinical correlation. Step 1, heart rate. The clinical correlation of the heart rate is either the heart rate is normal or there is tachycardia, bradycardia. Step 2 is heart rhythm. Any abnormal rhythm, heart block, PVC, and etc. Step 3 is P or interval. The clinical significance of PR interval is AV block, Wolff-Parkinson-White syndrome, and step 4 is QT interval. The clinical significance is heart rate and cardiac arrhythmias. Step 5 is axis deviation, hypertrophy. Step 6, ST segment abnormality, which occur in myocardial infarction. And step 7, abnormal P wave and interval, atrial enlargement. The clinical significance of P wave, interval or enlargement is any abnormality in the P wave is atrial enlargement. What is a normal adult heart rate? Normal heart rate of adult is 6200 beats per minute. Tachycardia is when the heart beats are more than 100 beats per minute, and bradycardia is less than 60 beats per minute. Regular heart rhythm. If a patient has a regular heart rhythm, their heart rate can be calculated following method. Count the number of a large square present within one RR interval. This is R and R wave, and these are the big square present between the two R waves. So count the big square between the two R waves. Divide 300 by this number to calculate the heart rate. Here in this picture, the big squares are 1, 2, 3, and these small square when added, there are become 4 big square in these two R waves. Heart rate calculation example. So divide 300 by 4, we will get the heart rate which is equal to 75 beats per minute. What if the second R wave does not match? Here you can see one R wave fall on the heavier line, but the second R wave fall on lighter line. So what we will do, how we will calculate the heart rate in this situation. Divide 300 by the number of large square plus find 2 per small square 8.2 to 1 small square. So here after heavier line there are 3 small square, 1, 2 and 3. Heart rate 4 large square plus 3 small square is equal to 65 beats per minute. When we multiply 3 by 6, the result will be 4.6, and when we will divide 300 by 4.6, we will get the heart rate 65 beats per minute. If there are 4 large square and 3 small square between RA, the heart rate is 65 beats per minute. 4.6 is equal to 65. Heart rate in irregular rhythm. How do we calculate if heart rate is not regular, such as in atrial fibrillation? It may be even easier, like finger counting. Usually electrocardiogram record 10 seconds. So all you have to do is count all QRS and multiply by 6. In 10 seconds, count the QRS and multiply it by 6. So you get the heart rate. If the ECG is not a 10-second one, or you are not aware of its duration, count 30 large squares, 6 seconds, and multiply the number of QRS complex on them by 10. The result is an approximate heart rate. Heart rhythm. The next step is to determine if the QRS complexes are rhythmic, if the RR interval distance between two QRS complexes are similar. If in doubt, make sure by using a compass or a ruler. So you can measure the distance between the RR complex by compass or ruler. Then you must determine whether the electrocardiogram is in sinus rhythm. If the interval is equal, the heart is in sinus rhythm. To do this, determine whether each cardiac cycle has a P wave generated by the sinus node, always followed by a QRS complex. When every QRS complex is followed by P wave, so this is a normal rhythm. If these conditions are met, we can say that the electrocardiogram is rhythmic and it has a sinus rhythm. When the distance between the two QRS complexes same, and when P wave is followed by QRS complex, when these two things are present in ECG recording, we say that the heart is in regular or sinus rhythm. PR interval. The PR interval normal between 0.12 second and 0.20 second are equal to 3 to 5 small squares should be measured from the beginning of the P wave to the beginning of a QRS complex. This is the beginning of the P wave and this is the beginning of the QR complex, and it should be equal to 0.12 to 0.20 second or 3 to 5 small square. A prolongation of the PR interval allows the diagnosis of first degree heart block. If this distance is more than 5 small square or 0.20 second, it shows that the first degree heart block. A short P interval allows the diagnosis of Wolff-Parkinson-White syndrome. If it is less than 0.12 second, it diagnoses Wolff-Parkinson syndrome. Prolonged PR interval. Prolongation of the PR interval above 0.20 second or 5 small square is called first degree atrioventricular block. If it is more than 5, here you can see that it is more than 5 small square or more than 0.20 second. So this is called first degree atrioventricular block. It indicates conduction delay from the sinus node to the ventricle. The atrioventricular node is the most commonly involved site in adult. In type 1 second degree atrioventricular block, which is also called Winkie-Beck phenomena, there is a AV conduction block with a progressive lengthening of PR interval of previous beat. There is progressive lengthening of the PR interval. You can see the PR interval here. It is further increased, and here there is a drop beat also. In other words, there is a progressive PR interval lengthening until a P wave is not conducted. Winkie-Beck phenomena. The PR interval become progressive, prolonged, and at one time there is drop of beat. The P wave is not followed by QRS complex, and there is no conduction from the SN node to the ventricle. This is called Winkie-Beck phenomena. Second degree heart block. In advanced second degree AV block, there are more than one consecutive blocked P wave. Conduction ratio 3:1 or more. You can see that the PR interval is prolonged and the P wave is not followed by QRS complex, and there are drop beats. The ratio is 3:1 or more. Here in this diagram you can see that after the QRS complex, two P waves are produced, but there is no QRS complex and there is no conduction of current from AV node to the ventricle. Identify the type of second degree AV block in such instance is also difficult. This type of AV block has higher risk and poor prognosis than previous one and can cause severe episode of symptomatic bradycardia. The patient will complain of slow heart rate, or he may also complain other symptoms like vertigo, blurring of vision, and fatigue. Advanced AV block usually require electronic pacemaker implantation. This type of block need implantation of pacemaker. Short PR interval. A short PR interval which is less than 0.12 second may be caused by a pre-excitation syndrome called Wolff-Parkinson-White syndrome, ectopic atrial pacemaker or AV junction rhythm. This may be result from Wolff-Parkinson syndrome or ectopic atrial pacemaker or AV junction rhythm. The most important finding in Wolff-Parkinson-White syndrome are a short PR interval. Here you can see that the PR interval is very short. The presence of the delta wave and wide QRS complex. This is a delta wave and wide Q, R and S complex. This is become wide. This is a normal QRS complex, and here the QRS complex become wide. In ectopic atrial pacemaker or AV junction rhythm may be seen in ectopic atrial pacemaker or AV junction rhythm may be seen a short PR interval with an abnormal P wave with narrow QRS complex. QT interval. The QT interval is measured from the beginning of the QRS complex to the end of the T wave. Here this segment is measured from the beginning of, this is the QRS complex, to the end of the T wave. It represents the duration of ventricular electrical systole, ventricular depolarization and repolarization. During this interval, the QT interval, first a ventricle is depolarized and then repolarized. The QT interval include the QRS interval, the ST segment and the T wave. This interval include the QRS complex, the ST, this is the S and this is the T segment, and the T wave, this is the T wave. It measures the total time of ventricular depolarization. Note the total time of ventricular depolarization. Its normal value range between 0.06 and 0.10 second. The QT interval vary depending on the QT interval varies depending on rate. It decreases at faster heart rate and it lengthens at slower heart rate. When the heart rate is fast, this is become shorter, and when the heart rate is slow, this interval is become prolonged. QT prolongation is associated with a risk for cardiac arrhythmias, giving that it can result in early after depolarization, provoke torcido de pointer, and lead to ventricular fibrillation causing sudden cardiac death. QT prolongation can be due to common genetic variation or the acquired long QT syndrome. Causes of QT prolongation. There are multiple causes and multiple drugs which cause QT prolongation. You can pause the video and read them. Short QT interval. A QT interval less than 350 millisecond is considered short QR interval. It is usually accepted as pathological. Again, there are multiple causes. You can pause the video and read them. P wave right atrial enlargement. The P wave represents atrial depolarization. It is the result of overlying electrical activity of both atria. P wave duration is less than 0.10 second and its maximum voltage is 0.25 millivolt. Normal P wave is positive in all leads except in AVR where it is negative and V1 where P wave is biphasic. Right atrial enlargement usually causes alteration in the P wave morphology. especially in its initial part. These are the initial part of the P wave. Right atrial enlargement causes an increase in the voltage of the P wave. This causes increase in the voltage of P wave higher than 2.5 millimeter. If there is no accompanying left atrial enlargement, there is no increase in the duration of the P wave. This high P wave with a normal duration is classically called P pulmonale. When the voltage is high but the duration is not increased, so it is called P pulmonale. It is seen more clearly in inferior leads. Normal cardiac axis. Typical ECG finding for normal cardiac axis. Lead 2 has most positive deflection compared to lead 1 and lead 3. In normal cardiac axis, lead 2 has positive deflection which is more than the lead 1 and lead 2. When you will see this type of finding on ECG graphs, so this is normal cardiac axis. Right axis deviation. Typical ECG finding for right axis deviation. Lead 3 has the most positive deflection and lead 1 should be negative. In lead 3 you can see in left axis deviation the deflection is most positive and in lead 1 it is negative. Right axis deviation is associated with right ventricular hypertrophy. When you will see this type of finding on ECG graph where there is more upward deflection and downward deflection of the lead 1, it is right axis deviation. Left axis deviation. Typical ECG finding for left axis deviation. Lead 1 has the most positive deflection. This is the lead 1 and you can see the positive deflection in lead 1. Lead 2 and lead 3 are negative deflection and there is negative deflection in lead 2 and lead 3. So this type of finding on ECG graph in which in lead 1 there is upward deflection and in lead 2 and lead 3 there is downward deflection. This is the left axis deviation. Axis deviation is associated with heart condition abnormality. Right bundle branch block, which is also called RBBB. Diagnostic criteria for right bundle branch block. The diagnostic criteria are 2. Broad QRS complex, which is more than 120 millisecond, or 3 small square or more than 3 small. Either it may be 3 small square or more than 3 small squares. RSR pattern in V1 and V3. When you will look at lead V1 and V3, you will find RSR pattern. This is called RSR pattern. RSR pattern in V1, V3 and initial small upward deflection R way, a large downward deflection S way, then another large upward deflection a second R wave which is indicated as R. P wave is followed by QRS complex, but in right bundle branch block, P wave is followed by R wave, then S wave, then again by R wave, and then a deep downward deflection of the S wave and then upward deflection of the S wave. This type of graph is seen in right bundle branch block where two R waves are present. Wide sludge S wave in lateral lead 1, AVL, V5 and V6. Normally the S wave is step and then flat, but in right bundle branch block in lead 1 you can see that it is wide and sludge, wide and sludge. Here in lead 1, V5 and V6. This is a sludge and a wide S wave. In right bundle branch block you can see in the ECG graph. Clinical relevance of right bundle branch block. Right bundle branch block can be either physiological or the result of the damage to the right bundle branch block. Causes of damage include underlying lung pathology, COPD, chronic obstructive pulmonary disease, pulmonary emboli, carpulmonale, primary heart muscle disease, congenital heart disease, which is ASD, atrial septal defect, and ischemic heart disease and primary degeneration of the right bundles. Left bundle branch block. Left bundle branch block. Diagnostic criteria for left bundle branch block. The diagnostic criteria for left bundle branch block are broad QRS complex more than 120 millisecond or more than 3 small square. These are the small square. If you will count, they are 3 or more than 3 small square. Dominant S wave in the V1. You can see that there is dominant S wave in the V1. Broad monophasic R wave in lateral leads AVL, V5 and V6. I will show you this in the next slide. Absence of Q wave in lateral leads and prolonged R wave 60 millisecond in lead V6 and V5. William mnemonic can be used to quickly recognize left and right bundle branch block by looking at the V1 and V6. V1 lead and this is the V6 lead. From here we can identify the right or left bundle branch block. To recognize left bundle branch block, we use name William and look at the first and last letter. The first letter is W and the last letter is M. If you will remember Willemia, so you will remember the left bundle branch block. W complex in the V1 resemble letter W. You can see this is resembling lateral W. Deep down deflection or dominant S wave. This is dominant S wave which may be notched. There is a notch in the S wave. M complex in V6 resemble the letter M. Broad notch or M-shaped R wave in the V6. Here you can see broad notch or M-shaped R wave in the V6. Left bundle branch block RS complex in V1. You will see in V1 RS complex thin R wave and deep S wave. This is a thin R wave and here is a deep S wave. Characteristic lateral lead morphology in V5 and V6. Note appropriate discordance in V1 with ST elevation and upright T wave. In V1, this is the V1, you can see that there is ST elevation and upright T. The ST elevation and upright T wave. Here you can see a notched R wave. Absence of Q wave in lateral leads. You can see that P wave is followed by Q wave. So in lead 1 there is no Q wave, absence of Q wave. In AVL lead there is also absence of, there is no Q wave. And in V1 absence of Q wave. Here this is the V1, so the P wave is followed by Q wave. There is no Q wave, but this is the R wave. Broad monophasic R wave in lateral leads 1 AVL and V5. Monophasic R wave with sludge down slope. In normal ECG the R wave fall sharply, but here it is falling down slowly and there is a notch in the R wave. Here you also can see the R wave and with sludge down slope. These you can also find in V5 and V6. Clinical relevance is always pathological. Left bundle branch block may be due to conduction system degeneration or myocardial pathologies such as ischemic heart disease, cardiomyopathy and valvular heart disease. Left bundle branch may also occur after cardiac procedure which damage the left bundle branch or bundle of His. Normal ST segment. The ST segment in normal condition is flat or isoelectric, although small variation up to 0.5 millimeter may be present. You can see that the ST segment is flat, and to determine ST shift, the segment between previous T wave and the actual P wave, previous T P segment is used as reference. If you are in doubt that there is any variation in the ST segment, so look for another QRS complex. If it is same with, if there is any variation from the previous one, so you can say that there is elevation, or if it is same with the previous one, so you can say that it is a normal ST segment. In case where the TP segment is not isoelectric, the PR segment is used, checked out the difference between interval and segments. A mild ST segment elevation, slight convex with normal morphology in right precordial leads can be observed in healthy individual. You can see there is convex ST elevation. This is usually present in healthy individuals. It is often observed during physical exertion, usually presenting a quick upslope crossing the isoelectric line. When there is physical exertion, there is upslope crossing from the isoelectrical line. This is normally found in exertion, especially when during exercise tolerance test. This segment become raise upslope, and then after rest this elevation come down to the normal level. On the ECG, the repolarization phase starts at the junction of J point and continue until the T wave. This is J point repolarization and continue after the T wave. Here are some MCQs. What is the heart rate in the following EKG? You can measure the heart rate easily and you can choose the right option from these five. Please pause the video, go to the previous slide, look for the formula and calculate the heart rate. Here a 60-year-old woman had the following EKG recording at a local emergency room following an automobile accident. Her weight was 70 kg and her aortic blood pressure was 140 by 80 millimeter of mercury. So looking on this graph, you can choose the correct option from these five. Please go to the previous slide and choose the correct option from these five options. Thank you. As a usual, request for subscription, down the bell icon for updating.